This is a presentation on pediatric HIV or AIDS. First of all, we'll start with what is HIV. Most of us know this stands for human immunodeficiency virus. It is transmitted during pregnancy from mother to fetus, during childbirth, while breastfeeding, and other forms of exposure to bodily fluids. Without treatment, it will replicate itself within the body, which eventually leads to severe immunodeficiency, chronic illness, and death. What is AIDS? This is the advanced stage of HIV infection. It's characterized by severely diminished immune system function. In most cases, a person living with HIV eventually develops AIDS. At this point, the body is highly susceptible to infections that are typically fought off by a healthy immune system. The U.S. Centers for Disease Control and Prevention states that a person has AIDS when HIV has drastically reduced the CD4 cell count, or when a person living with HIV is diagnosed with at least one opportunistic infection. And that is an infection that does not normally occur in someone with a healthy immune system. Some facts about AIDS. You cannot tell if someone has AIDS by looking at them. There is no cure or immunization. It affects people of all ages, races, socioeconomic status, and sexual orientation. No cases of AIDS have been reported due to kissing, biting, or mosquito bites. It is not transmitted through touching or hugging, and it cannot be contracted from donating blood. There are also no reported cases of HIV being transmitted from child to child or child to staff member in a school building. I know this graphic might be a little bit hard for you to read, but I thought it was an interesting timeline of pediatric HIV and AIDS cases, and the link is there where I found it. It outlines HIV cases among children in the U.S. Most of us might remember Ryan White, who was diagnosed in 1985, and then his subsequent death in 1990. By 2002, 13 million children were living with HIV. So we'll talk about a little bit about prevalence of HIV among children in the U.S. I am focusing this PowerPoint presentation on statistics in children in the U.S. Clearly, HIV and AIDS is a global problem, but for these purposes, I'm just specifically going to talk about the U.S. So it affects approximately 1.8 million children under 15 years of age. Nearly 36.9 million people worldwide are affected. 130 cases of HIV in children younger than 13 were reported in the United States in 2016. That's the most recent data that I found. And in the U.S., the most common way that children under 13 get HIV is through mother-to-child transmission. So more than 90% of infected children contract HIV this way during pregnancy, childbirth, or breastfeeding. And then most youth who get HIV during adolescence are infected through sex. So most new HIV infections among youth occur among gay and bisexual men, with young African American and Hispanic gays and bisexual men especially affected. So how does HIV affect children? You might see frequent ear and sinus infections, sepsis, pneumonia, urinary tract infection, intestinal illness, skin disease, meningitis. Children's immune systems are not fully developed, so children living with HIV get sick more severely than adults. They cannot fight these infections as effectively. And then in developing countries, tuberculosis, diarrhea, and respiratory illnesses are more common. So some physical impairments are listed here. And these are going to vary according to your physical condition and the impact of the opportunistic illnesses that I previously mentioned. Here is a list of neurological impairments 75 to 90% of children infected with HIV experience neuropsychological deficits. While HIV-related neurological impairment in children is commonly associated with cognitive delays, neurological impairment in adolescents is more commonly associated with cognitive deterioration. Neurological damage commonly results in the death of children with AIDS. Here's a list of social impairments that come with having HIV or AIDS. Many of the symptoms reported by children with AIDS are similar to those experienced by children living with other chronic illnesses. Here's a list of some additional risk factors, including chronic poverty, housing problems, nutritional problems, poor access to medical services, exposure to dangerous environments, and then there is a stigma that is associated with HIV and AIDS, which is a result of fear and discrimination. Attempts have been made to deny rights to individuals with HIV or AIDS, including the right to employment, the right to a free and appropriate education. There are federal and legal mandates that attempt to protect the constitutional rights of people with AIDS, but stigmatization and discrimination still persist. Some adolescent risk factors. Several factors make it challenging to prevent HIV among adolescents. They lack basic information about HIV and how to protect themselves. And some of this includes low rates of condom use, high rates of STDs, and alcohol or drug use. So always using a condom correctly to reduce the risk of HIV infection is clearly one way to prevent, and adolescents don't always use these correctly. Having an STD increases the risk of getting or spreading HIV, and then alcohol or drug use make adolescents more likely to engage in risky behaviors, such as having sex without a condom, which then leads to an increased risk for contracting HIV. When we talk about prevention or treatment, one of the ways to do this is through antiretroviral therapy, or ART. This is the most effective method for preventing mother-to-child transmission, and it is recommended for everyone with HIV, including children and adolescents. Another treatment is antiretroviral drugs, ARV drugs. And these decrease the amount of the virus in the mother's bloodstream, which reduces the risk that she will pass the infection to her infant. These drugs also have a protective effect on the child before and after birth. If a woman is not eligible for ART or it's not available, then drugs can be given to her starting early in her pregnancy and to the infant immediately following delivery. And then extending the antiretroviral drugs while breastfeeding also decreases the likelihood of HIV transmission via breast milk. It is estimated that there are approximately 8,500 HIV positive pregnancies in the U.S. each year, but less than 150 new infant HIV infections. So this is a testament to the effectiveness of these prevention efforts. The use of HIV medicines and other strategies have helped to lower the risk of mother-to-child transmission of HIV to 1% or less in the United States and Europe. Early detection, medicine regime, and scheduled cesareans keep the risk of transmission low. So medication for children and adolescents. Growth and development and medication adherence both affect HIV treatment in children and adolescents. It's important that they take their HIV medicines every day and exactly as prescribed. Dosing of medicine is not always based on age, so weight or stage of development are also considered. And then children with HIV may use different forms of medicines than adolescents or adults. So some HIV medicines come in a liquid form, which can make it easier for infants and young children to take. Problems that arise with medication adherence among children are listed here. You can imagine that having to take drugs multiple times a day would cause problems for some children. And then adolescents tend to skip medicine doses to hide their HIV positive status from others. So what can we do in the schools and in the classrooms? Here are some best practice for the classroom. Teachers have a responsibility to educate themselves about HIV and AIDS. We must be knowledgeable about how it is transmitted and how it's prevented so that we can then educate students about how to protect themselves. We should also model appropriate behavior that emphasizes problem solving and informed decision making, and behavior that discourages discrimination and prejudice. Knowledge and behavior are necessary when we want to calm students and parents' concerns about children with HIV who might be being educated in the regular classroom setting. Teachers cannot be fearful if there's a student with HIV/AIDS in their classroom. There are no documented cases of AIDS transmission due to casual contact, biting, fighting, or contact sports. Teachers must respect students' and parents' right to privacy and be aware of and abide by the confidentiality and disclosure laws and policies within their school building and their district. And then universal precautions should be maintained when coming into contact with blood or other bodily fluids that may contain blood. This refers to the use of gloves and disinfectants when in contact with blood or blood-contaminated products. Some important school issues. School-based health services must be provided to children, adolescents, and their families. Schools are continually recognizing the impact that health issues have on academic functioning, and we need models of healthcare delivery to be incorporated into our educational systems. Potentially all members of the school community are affected by this disease, and programs need to be designed to confront this reality. Academic and social environments must address the needs of the students, but also others affected by the AIDS crisis, including peers, teachers, and administrators. So it's important that programs should incorporate the goals of primary, secondary, and tertiary prevention, and I've explained what each of those are. Tertiary prevention is the development of programs and interventions for those that are already infected and those directly impacted. Secondary prevention are groups who are at risk for contracting HIV. And then primary prevention is community-wide programs that make everyone aware of the threat and the impact of AIDS. Primary prevention is the most global and pervasive form of prevention, and it creates a foundation reinforcing the need for school, community, and healthcare communication, coordination, collaboration, and commitment. Here's a list of relevant websites that you can go to visit to get more information, and all of these were websites that I visited to gather my information from. Some multiple choice questions for you, and the correct answers will follow. How many cases of HIV have been reported from child to child or child to staff member in a school building? In the U.S., the most common way children under 13 get HIV is through mother-to-child transmission. True or false? How do most youth who get HIV during adolescence get infected? Which of the following is not an associated physical impairment of HIV? And teachers do not have a responsibility to educate themselves about HIV or AIDS. True or false? And here are the answers to the multiple choice questions. Here is a handout that is good for schools to use. It has facts about HIV and AIDS. And now we'll talk about the case profile for Daniel. He's a 15-year-old male. He's enrolled in Lake Point High School in the 9th grade. He has been diagnosed with HIV. He currently lives with his mother, and his father left the home 1 year ago. Academically, Daniel is a good student. He's maintaining a 2.95 GPA. Socially, Daniel is somewhat withdrawn and he has few close friends. So the problem that we're going to discuss today is his refusal to take his medicine at school. and also his social issues. So his first goal will be to improve Daniel's level of compliance when taking medicine at school. The baseline measurement, the school nurse reports that Daniel is currently following his medicine regime correctly about 2 out of 5 times per week with 3 reminders. So the objective is that after he receives 1 remind text from the school nurse, that he will respond within 5 minutes and arrive at the nurse's office within 10 minutes, ready to take his medicine on all 5 school days. This will be monitored by the nurse recording what time she texts Daniel and what time he arrives in her office. This information will be emailed to his mother at the end of each school day, and he will receive his weekly allowance once he has taken his medicine on all 5 school days. The second goal is to help Daniel become more socially involved in his school by talking to the guidance counselor, keeping a journal, and attending school functions. So Daniel has never visited the guidance counselor. He does not currently keep a journal, and he has never attended a school function. So the objective is that after visiting with the school guidance counselor once a week, Daniel will write his thoughts in a journal and plan 1 social outing per month for the first semester, 2 outings for the second semester, and so on. So the way that we're going to monitor this is that the guidance counselor will set up the meeting each week according to Daniel's class schedule. They will meet for 30 minutes to discuss any issues Daniel is having. He'll write a journal entry each week following this discussion, and then he and the guidance counselor together will look at the school events calendar and choose an event each semester that he will attend.